Hi everyone, I'm Bree. I'm going to be taking you through chronic diseases and preventative health in preparation for your Year 4 exams. Before we started, just wanted to give a massive shout out to all the other previous years' lectures, revision lectures. They have some wonderful resources there. A lot of the information I got is from the Red Book, especially for the preventative health portion of it, and ETG as well. GPSN also has a lot of amazing resources and study packs, and we're also releasing a MCQ study pack this year as well for you guys. So keep an eye out for those as well during the revision period. As always, if you have any questions, please feel free to email me or to find me on Facebook and message me. I'm very happy to answer any questions. And if there's any mistakes or anything in the slides, just let me know as well. Perfect. So this is what we'll be covering in the lecture today. We'll be starting with some management principles, lifestyle recommendations for all chronic diseases in general. This will form any part of your any management plan that you make for GP for chronic diseases. Then we'll go through some specific conditions, in particular diabetes, hypertension and dyslipidemia, COPD and asthma, heart failure and AF, and then we'll look at some prevention and screening programs that you should be asking your patients about always. So what I thought we'd start with is just looking at DKA empire. So this is a nice general structure for when we do our management plans in GP. So it stands for diagnosis, knowledge, attitudes, educate, management plan, prevention, information, reinforcement, evaluate, and safety netting. You don't necessarily have to follow it in this order, but I do like having it written down on my sheet during an OSCE, just so that I can tick it off as I go to make sure that I've covered everything that needs to be said when explaining a diagnosis or when diagnosing a patient with something or explaining something to them. So diagnosis, we state it. So it might come in the form, or you might say something along the lines of, after listening to your story and having an examination of you today and looking at the the blood test that we've done, this suggests that you have a diagnosis of whatever it is. Have you ever heard of this before, or what do you know about this? That's checking their knowledge of it. How do you feel? Is there anything in particular that concerns you? Attitude. And then you just explain it. And you want to make sure that you're doing it in without any medical jargon, so real bare bone explanations. Work through what it is, and you sort of can work through your notes when you're educating a patient about it. So definition, epidemiology, if there's something really important there that you want to talk through them with. You can link it to their symptoms and signs as well, so that the patient is able to see, oh yes, that matches what I've been experiencing recently. And then that will lead nicely into your management plan. So with our management plan, it's good to always split it up into like lifestyle or non-pharmacological versus pharmacological things. Or you can also do short-term versus long-term, depending on what the condition is and what's most appropriate. Then after that, what we would do is we would do prevention. So just while we've got you here today, this is a good opportunity for me to just check that you're up to date with all our screening programs available. Of course, this differs depending with the age of the patient. So things you might ask about include like breast cancer screening, mammograms, FOBTs, vaccines for kids in particular, cervical screening tests, etc. Then we always provide some information. So if you'd like, we can print out some information for you to take home and do some more reading on it. So just offer it. Reinforce and ask them if they have any other questions that they'd like to ask you before you end the consult. With safety netting, you always just want to point out some red flag signs of when things might mean that they're deteriorating or the condition's getting more serious, and advise them to either come back to you as a GP or to go to ED afterwards. Perfect. So I put a little case study here. So what we're going to do is we're going to try and explain a management plan to the mum of this child. And so what I'll do is just having a look at the picture. So Mrs. X presents to you with her daughter who's 5. Please explain your management plan to her. So just looking at this picture, think what's the rash suggestive of? And hopefully you get a diagnosis of that presents. You can see that's on a flexural surface. It's not really well demarcated. It's erythematous. It looks like it's got some scratch marks on it. Looks, it looks a bit like eczema, hopefully, is what we got. So sorry, before I show you that, try and write out or try and practice a diagnosis or a management plan, sorry, using DK empires. And I've just left an example there for you. And you guys can read through that in your own time as well. Perfect. All right. What we might move on to now then is SNAP-W or lifestyle management. So these are things that we can advise most patients of into that first section of our management plan, so our non-pharmacological management plan. So S stands for smoking cessation. So we always ask, are you a current smoker or have you ever smoked? Have you ever smoked before? And if they have smoked, we ask how much. And then have you ever thought about quitting? If they say that they are sort of on the pathway of thinking about quitting or they would like some resources to help them with quitting, things that we can suggest or resources that we can suggest include Quitline, behavioral support through CBT. We can assess their nicotine dependence as well. And then there's also pharmacotherapy for that. So we've got replacement patches. It comes in like a gum form as well. And then we also have like medications, which you'll probably learn more about in psych. And it's for nutrition. So in our histories, we generally ask, can you tell me a little bit about what you eat and what you drink? Do you have a lot of sugary drinks? Do you have a balanced diet? Do you eat your veggies? How many times a week do you tend to get takeout? We can refer to a dietitian where appropriate as well, and we can apply some SMART goals there if the OSCE is centered around nutrition in particular. A is for alcohol. Again, we ask, do you currently, or do you drink alcohol? How much do you drink? How much do you drink through a week? And then you can ask your cage questions. So, do you ever use it to, you ever drink alcohol in the morning in particular? Do you feel guilty when people ask you to cut down, etc., etc.? Ideally, they shouldn't be drinking more than 10 standards a week and no more than 4 a day. And there's a high risk of thiamine deficiency with high alcohol intake, and we know that that's linked to our Wernicke's and Korsakoff's encephalopathies. In terms of what we can do and what we can offer AA, drug and alcohol counselling and education. We can also suggest some pharmacotherapy, so things like acamprosate, naltrexone, disulfiram. Those are all of our different options, and I think it's good to know what the sort of dosing regimen is for each of those, as well as some common side effects and whether they interact with the alcohol, as well as some important things to know about these particular medications. In particular, disulfiram is the one that if they drink alcohol whilst being on this medication, they get symptoms. So that is a really good option, or that's how you differentiate it in an MCQ per se. P is for physical exercise. So do you currently exercise or do you tend to like have a very sedentary lifestyle? Well, our aim is for 30 minutes 5 times a week, ideally. And again, we can do our SMART goals. So starting low, maybe just doing some walks or doing some light swims, and then increasing that appropriately as well. And having someone to keep them accountable is often really good. And then W is for weight. So is their BMI currently elevated, and by how much so? So looking at the BMI sort of categories. Of course, we have to remember that BMI has its limitations in itself. And then we can also offer some pharmacotherapy as well in certain cases for weight loss as well. But again, advocating for physical exercise, nutrition, etc., as first line for management of weight loss. In terms of the behavioral change model, this is more relevant if you have like an alcohol or smoking cessation station. So things we want to do is ask. So ask them if they're currently eating or if they're currently smoking, drinking, etc. Assess how much. Advise them on, why this is bad for them, what could possibly go wrong, and how this could impact them, and then assist them. So that's where we put in our DK Empires plans. Arrange follow-up and always check in. So these are the 5 A's that you can just sort of tick off as you're assessing risk. And it works for everything, not just alcohol and smoking, but also when we're thinking about like the need for behavioral change to prevent things like diabetes, osteoporosis, etc. Things with modifiable risk factors. All right. So we might look into some specific conditions now, the first being diabetes or type 2 in particular. So we should already know a few things about type 2 diabetes from third year. So definition, how would we explain it to a patient? You might say something along the lines of like, Have you heard of diabetes before? How do you feel about it? Is there anything in particular that concerns you about it? What I can tell you is that means that your sugars in your body are typically higher than what they should be, and your body's having some difficulty regulating the levels of sugar in your blood. Something simple. From third year, we should also know our risk factors, which of course we can split into non-modifiable versus modifiable. We should know our clinical features, our signs and symptoms, our complications, in particular the 3 macro and microvascular ones. These are particularly important to know because we want to be making sure that in our GP consults, we're always checking for them, and we're advising them that they should go and check with their relevant specialists or the podiatrist, etc., every year or 2 years, and making sure they're on top of that. We should also know our medications for diabetes as well, and how they work and their common side effects. But we'll go into medication management a little bit here as well. Perfect. So with type 2 diabetes, for diagnosing it, there are 3 things that we can look at. So the first, which I've written last, is the HbA1c being above 6.5%. So if that is above 6.5%, that's a diagnosis of diabetes without any other questions that need to be asked. If it's between 6 to 6.4, that's pre-diabetes. So you've got some room to sort of prevent a formal diagnosis, and there's sort of some leeway there. But anything above 6.5, we would say is a diagnosis of type 2 diabetes. Otherwise, if they're symptomatic, they only need 1 abnormal blood sugar reading. Or if they're asymptomatic, they will need 2 abnormal sugar readings. The different sugar readings that you can look at are things like the OGTT, a fasting blood sugar, or a random blood glucose as well, or work. And this is from the Red Book. In terms of screening and how often we do it, we can use the OSRIC tool. This is just a questionnaire, and you put in like the patient's details in it, and it tells you the risk of diabetes and how often we should test them. However, normally we do it every 3 years from the age of 40 if they're non-Indigenous, or annually from 18. And again, if OSRIC suggests that they're high risk, they undergo diagnostic screening using the HbA1c, fasting blood glucose, or an OGTT as well. So we can see a diagram here. I think this is from RACGP. Sorry. So from here we can see that if the fasting blood glucose is below 5.5, diabetes unlikely. We can retest in 3 years. 5.5 to 6.9 in fasting is possible, so we do an OGTT then. And then if it's above 7 fasted or 11.1 randomly, then we would do another confirmation test to confirm that the patient has diabetes. And again, this is important to note that it's an asymptomatic population, so therefore we need 2 abnormal readings. You can see 1 and then 2. When we're testing HbA1cs, you can just use that one number, definitely. And I've just got the numbers there for you again. So fasting blood glucose above 7, random above 11, should be 11.1, HbA1c above 6.5%. Again, if we want to check for type 1 diabetes as a differential, we can do our markers for those as well. And then once someone's got a diagnosis of type 2 diabetes, what we have is some management targets for bloods. So this is once they're diagnosed, they're on treatment, whether that is non-medicated or medicated. There are some management targets that we have for blood. So fasting between 4 to 7, random between 5 to 10, and a HbA1c equal to or less than 7%. And you might see that in an older population group, they're a bit more lenient with the HbA1c being a little bit higher. That's just because of the risk of hypoglycemia. And we don't want them having falls if we can avoid it. In terms of management of type 2 diabetes, again, we have a non-pharm versus pharm. So non-pharmacological management includes SNAP-W. In particular here, we would refer to a dietitian and a diabetes educator. So that's sort of like the allied health team that you would link in. We get them to regularly check their blood sugar levels, and the diabetes educator will be happy, is often the ones to teach them how to use the finger prick. And then every 3 to 6 months, we'll be checking their HbA1c, blood sugar levels, blood pressure, BMI. And every 12 months, they need eye checks, renal function, and lipid levels as well. In terms of pharmacological management, there is a really good RACGP algorithm for medications, which we'll go over in the next slide. But key medications to know, and also note their side effects, things like metformin, SGLT2 inhibitors, GLP-1 inhibitors, and DPP-4 inhibitors. And again, we often review our medications and adjust them as need be. So this is the from RICGP, the management algorithm, and you'll see that it goes from monotherapy to dual to multiple therapies, and then we consider insulin. Monotherapy is typically with metformin and metformin alone, so knowing the side effects and being able to counsel metformin is particularly important. Dual therapy, we might add an SGLT2 inhibitor, a GLP-1 or a DPP-4. Again, you can see the green meaning that these two are more common, and then etc. for multiple therapies. All right. Next, we might go into hypertension and dyslipidemia. I've just put there like the blood pressure categories and how abnormal they are as well for you to look at. All right. So with high blood pressure, this is all from the Red Book and RICGP. Normally, we should be measuring blood pressure every 2 years in adults over age 18. We use the absolute cardiovascular disease risk assessment calculator tool after the age of 45 or 35 if they're Aboriginal or Torres Strait Islander. They've recently changed not recently, as in like when I was in fourth year, they changed the low risk, medium, high risk percentages. So we'll go through that in a second as well. The things that the calculator or the risk assessment tool needs is the patient's sex, age, systolic blood pressure, smoking status, cholesterol and HDL, diabetes, if it's present or not, and then an ECG for potential left ventricular hypertrophy if it's available. In terms of the risk, so low risk is now defined as less than 5% in the next 5 years. And if that's the case, we measure blood pressure every 2 years. Moderate risk is 5 to 10% absolute risk. And in this case, we would measure blood pressure every 6 to 12 months. And high risk is now defined as more than 10% of absolute risk. And in this scenario, we would do blood pressure every 6 to 12 weeks. Regardless, with hypertension, we can always advise lifestyle recommendations. So again, that's your SNAP-W. So things like encouraging physical activity of at least 30 minutes 5 times a week, recommending for them to stop smoking if they are, aiming for a healthy BMI, encouraging salt restriction, and then encouraging limiting alcohol intake as well. So you can see here an example of the risk calculator. And on the left-hand side, you have one from the Red Book, blood pressure, and when we start to measure it in red. Again, this is just like grades of hypertension, depending on the systolic and diastolic. In terms of management, we've been a little bit through the lifestyle already. So second line would be pharmacotherapy. So the question becomes, when do we start pharmacotherapy? So we only start it if it's high risk is guaranteed start, and we would start that with a statin as well. But if it's medium risk, we often give them an opportunity to use lifestyle management to see whether that's been effective or not. And then afterwards, if it's not effective or there's minimal change of blood pressure, then we would start it. But in low risk, we don't start any hypertension management, of course. The target blood pressure is below 140 or 90. So often the drug for first line treatment is an ACE or an ARB, a calcium channel blocker or a thiazide diuretic, but we never start with a beta blocker, which is important to know. In particular, we would start the patient on a calcium channel blocker as first line if they have lots of vascular risk factors or if they're over the age of 55 in particular. Often we start over the very low dose of the first drug, and then we'll up titrate that before adding a second drug because of the risk of interactions, but also side effects that increase when adding another drug as well. And again, if they're high risk, according to ETG, we give blood pressure lowering as well as lipid modifying drug therapy at the same time. With these medications, it's very common to be asked about side effects, and it's very important that you are able to counsel them adequately. So things to note with an ACE inhibitor, it's all contraindicated if the patient has bilateral renal artery stenosis. We want to make sure that we avoid the triple whammy, so ACE, diuretics, and NSAIDs. If they're pregnant, no ACE or ARBs as well. And side effects include a drop in renal function, and that is mostly temporary, but we want to watch out for it. A dry cough, a swelling, or especially around the lips, and then a raise in potassium as well on blood tests. With calcium channel blockers, some adverse effects that you'd want to consider telling the patient about include peripheral edema, so swelling of the ankles, hypotension, and bradycardia. Perfect. And again, combinations that are common to occur. So you might start someone on an ACE or an ARB and then add a calcium channel blocker, so that might be your second line, or you might start them with an ACE or an ARB and then add a thiazide as well. But typically, like beta blockers aren't your first line. It's important to know. Dyslipidemia. So screening for abnormalities in lipid levels. We only do this from the age of 45, and then we only do it every 5 years if low risk. If they're low risk, again, we repeat it every 5 years. If they're medium risk, so 5 to 10% on the calculator, then we would provide lifestyle advice and consider pharmacotherapy, but that's after a trial of lifestyle therapy alone. Then after that, we would repeat lipids every 2 years. So instead of 5 years, every 2 years. And then high risk is we commence cholesterol lowering therapy with antihypertension medications and repeat the lipids every 12 months. Again, sorry, I just made a mistake. And the high risk should be above 10%, not above 15%. So for under 5% for low risk, 5 to 10% for medium risk, and above 10% for high risk. Again, this is all from Red Book, but this is from the old Red Book when the percentages were a bit different. The boundaries were a bit different. Then we have our targets. So this is when, the first group is abnormal concentrations of lipid in the blood. So when these are the upper limits of normal. So 5.5 for total cholesterol, LDL cholesterol above 3.5, HDL cholesterol below 1 or 1.3, and triglycerides above 2. And then once we're on lipid lowering therapy for primary prevention, so that's they haven't had a heart attack or a stroke or something yet, we have aims for the bloods for the lipid levels. And an easy way to remember this is 4221. So total cholesterol below 4, LDL and triglycerides below 2 is the aim, and HDL above 1 is the aim. For secondary prevention, the targets change a little bit, and I don't think you have to know them per se, but it's just good to know that the targets of what we're aiming for are changing, and you can see them there for you. Pharmacotherapy. The first line is always non-pharmacological, non-pharmacological, and then first line pharmacologically is statins. Important to know how to counsel these drugs as well. The side effects include myalgia, myopathy, liver or renal function deterioration, and an AKI. Second line depends more so on what you're targeting specifically. So ezetimibe lowers LDL levels in particular, fibrates lower triglyceride levels, and PCSK9 inhibitors have more to do with LDL as well. But important to know that fibrates are the ones that lower triglycerides. Cool. COPD and asthma. So asthma, I think, is actually being covered in acute GP emergencies, but just a reminder of things to know. So definition, epidemiology, signs and symptoms, severity, pathophysiology briefly, and then management. So what would we do in an acute attack? What do we do once someone's being diagnosed? How do we prep them for long-term management? And then we also want to be able to explain how to use a puffer like Ventolin and how to counsel parents on how to appropriately use a puffer. As well as this, if you haven't already, have a look at what an asthma management plan looks like as well. But I also have that for allergy and anaphylaxis. So in peds, that might be particularly important to know. Right. The other one that we were looking at is for airways is COPD. So revision, COPD is an obstructive lung disease caused by irreversible airway obstruction from inflammation. Diagnostically, our FEV1 over FVC ratio is below 70%. Risk factors we can break up into modifiable versus non-modifiable. And then we have two etiologies, chronic obstructive bronchitis versus emphysema. And you can see that in the image there as well. It's quite well differentiated. We can also classify COPD based on severity as per ETG as well. So here you can see the ETG classification of COPD. And we can either do it based on lung function tests or we can do it based on symptoms. In terms of management of COPD, so we can do something known as COPDX, and then lifestyle measures, and then medications. So COPDX is an acronym used for COPD management, and so it stands for C, confirm the diagnosis via symptoms and investigation, so that's like your lung function. O is to optimize function, and that's our ADLs, or activities of daily living. We have our personal ADLs as well as our instrumental ADLs, and depending on which one's affected can also influence the severity of the COPD and how you might describe it. P is for preventing deterioration, so taking a preventative approach. D is for development of a care plan, and then X is for managing exacerbations. In terms of lifestyle things, we'd strongly advocate to stop smoking because it's the only intervention shown to improve the natural history of COPD. Treat poor nutrition, mental health support, ensure vaccines are updated, especially influenza and pneumococcal vaccines, and then pulmonary rehab in some cases as well. In terms of medications, we follow a stepwise approach. So this is from the COPD management, I think from RACGP or from the Lung Foundation. But most of the time we start with a SABA or a SAMA, and then we add monotherapy of a LABA or a LAMA. After that, we would add dual therapy of a LABA and LAMA. This is done based on symptoms. So if we're finding that the monotherapy isn't enough to control symptoms, we would move up to dual therapy. And then there's specific criteria that need to be met to move on to triple therapy. So triple therapy is our LABA, LAMA, and ICS combination. And the only reason why we would do this is A, if the patient has had a severe exacerbation that's needed hospitalization. B, if they've had 2 moderate exacerbations in the last year, or C, if they're still symptomatic despite dual therapy as well. This is the ETG equivalent of the Lung Foundation's diagram. And I've also included there the COPD action plan as well, and just having a look at that. It's a bit similar to the asthma one, but you might have to fill this out in GP for some of your patients. So it might be useful just to have a look and see what it looks like as well. Again, remember that our oxygen aim for our patients with COPD, especially if they're CO2 retaining, is 88 to 92%. If they have a flare-up or an exacerbation, things that we would do include antibiotics if it's infective, or prednisolone, or some sort of steroid as well. Heart failure and AF. So heart failure, just a reminder, is when there's a structural or functional impairment of the heart that reduces either ventricular filling or ejection. So we have HFrEF or HFpEF. Etiology, you can have a read. Exacerbating factors, you can also have a read. Important to note that diagnostic gold standard is our TTE, and primary prevention involves treating any potential causes early on. In terms of management, there's quite a bit that we can do. For lifestyle, again, SNAP-W, patient education, alcohol, fluid restriction, salt restriction, exercising, stopping smoking, etc. Want to try and increase their capacity and their ability to do their everyday things, so their activities of daily living. In terms of drug therapy, it differs between reduced ejection fraction versus preserved ejection fraction. So if it's a reduced ejection fraction, there's 4 medications that we would prescribe. So one is a renin-angiotensin system inhibitor. So you've got some choices there, whether that's an ACE, an ARB, or an ARNI. The second is a heart failure specific beta blocker. The third being a mineral corticoid receptor antagonist. And then the fourth being an SGLT2 inhibitor. Your choice of a renin-angiotensin system inhibitor is typically based on patient tolerability of side effect profiles and efficacy. Typically, either the ARNI or the ACE is first line, but often some patients don't can't tolerate the dry cough, so that's why they might change from one to the other as well. We also need to remember that if we are changing from the ACE inhibitor to another medication, an ACE inhibitor has a washout period of 36 hours, so we don't want to be double dosing by accident within that 36 hours. So let the medication be completely removed from the patient system before adding on a next medication as well. It's important to note. With our spironolactone, so our mineralocorticoid receptor antagonist, because we're adding it on top of an ACE inhibitor or an ARB, there is that potential for hyperkalemia. So it's just important to monitor that in the long term and throughout their treatment, especially if they have a low EGFR or renal failure as well. That would put them at a higher risk of hyperkalemia and all the side effects associated with it. Typically speaking, as soon as we diagnose reduced ejection fraction, heart failure, we would start all of these medications within 2 to 4 weeks of diagnosis. And then we would slowly up titrate the doses depending on whether it's controlling symptoms or not and whether we're seeing an improvement in the clinical signs as well. But monitoring electrolytes, as mentioned, is very, very important. So you can see this chart for management as per ETG. So you can see that if the patients can euvolemic, we'll start here. At diagnosis or within 2 to 4 weeks, we would start the ARNI or ACE, the beta blocker, the spironolactone, and the SGLT2 inhibitor. So that's all 4 medications. But if they're congested, so they're overloaded, then we would start everything except the beta blocker and only start that when they're euvolemic. HFpEF is only needs 2 medications, so lifestyle is still the same. We'd always advocate for lifestyle management. And then pharmacological management, there's 2 things that we would give. So the SGLT2 inhibitor and the beta blocker. Cool. Atrial fibrillation. So again, our definition is revision. Irregular tachyarrhythmia when there are multiple electrical waves resulting in the failure of the atria to contract. And so instead the atria fibrillates. It tends to be in the left atrium where the pulmonary veins enter, and it's associated with hypertrophy of the left atrium. You can see an ECG there as well of what AFib looks like just for revision. In terms of classification, we can classify them 2 different ways. So based on how long it's been there for. So paroxysmal being resolved within 7 days of onset, permanent being for more than 7 days. Persistent being for more than 7 days, and permanent being for more than a year. Alternatively, we can classify AFib based on rate, so rapid versus slow, and that's when we're looking at the heart rate, so above 100 versus below 100. Etiology and exacerbating factors you can have a read of, and then also just review the risk factors and classical symptoms of AF as well. But what we'll be looking at more is the management of AF. So there's 5 main aims, or there's 5 main priorities for the management of AFib. The first will be to manage the thromboembolism and stroke risk. You would have to use a CHA2DS2-VASc score to determine if the patient needs anticoagulation. And you're definitely not expected to memorize the CHA2DS2-VASc score. You will be provided this if it's required to be used in an OSCE stem. But just be aware that it is something that you might have to ask for. The second priority in management is symptom relief. So whether that is rate control or rhythm control. Typically speaking, rate control is a priority, especially if it's fast AF. And the first line here would be beta blockers. So whether atenolol or metoprolol. Or we can also use our heart failure specific beta blockers if the ejection fraction is below 40. So if they're in HFrEF. Second line would be a calcium channel blocker. And then third line would be digoxin. For rhythm control, we can do it through medications, or we can do it through like cardioversion or catheter ablation to restore the rhythm. Our options for that would be flecainide, sotalol, or amiodarone. Flecainide is often first line, and there's this concept of pill in the pocket. So pill in the pocket is a type of cardioversion that we give to the patient. It's a single dose of oral flecainide to restore sinus rhythm. And so the patient can self-administer this at home if they have infrequent symptomatic episodes of AFib. Sotalol is more used for long-term control, but but note that it can increase the QT interval. So we do want to be checking ECGs to prevent this or to catch on to it early if it does happen. But we would want to do like cardioversion or catheter ablation, especially in our younger fit patients. Oh, sorry. The third priority of AF management is to manage comorbidities. 4 is to consider the need for cardioversion. And then 5 is to treat any underlying disease or the underlying cause where appropriate. Again, you can see here this is from RACGP, the AF sort of flowchart. So diagnose the AF. Can we find something that is causing it? Can we rhythm control or are we going to rate control? And you can see here the different ways that you can do both of those things. Perfect. The last little thing that we'll chat about is screening programs. So there's many types of screening programs, or a few that we need to know about, but in particular, one of the big ones is colorectal cancer. So why is it so important that we screen for it? It's because it's the third most commonly diagnosed cancer in Australia, and catching it onto it early can help to reduce disease burden and get us onto treatment pathways quicker. Risk factors include age being over 50, family history, IBD, male, Western diet with high red meat consumption, or Lynch syndrome. So the screening program itself is the National Bowel Screening Program. And the criteria to fall into this is if you're between 50 and 74, then you do 2 yearly FOBTs. So it's a stool sample or stool test kit that gets sent to your mail or to your post box every 2 years. They do a bowel action, smear a little bit, and then send it back off. Just know that we don't do an FOBT if they have macroscopic blood. So if the patients come in and telling you that they've had a PR bleed or they've noticed some fresh blood in their stool or when they did a bowel action, we wouldn't be doing an FOBT because that would be positive anyways. Because what the FOBT is looking for is microscopic blood. If positive, we send for a colonoscopy. Again, this is the red book that tells us sort of category 1, category 2 based on risk and how often their screening needs or what their screening needs to look like. So you can see category 1 would be most people or people with who are asymptomatic with no family history. And that's every 2 years from the age of 50, we would do an FOBT. And then if they have a relative, depending on how old the relative was when they were diagnosed, that changes their screening. I've just continued it here as well, so for high risk population. Breast cancer screening program. So risk factors: female, being over 40, family history of breast cancer, ovarian cancer, endometrial cancer, nulliparous women, BRCA1 or 2 genes, having a family history of male breast cancer as well, and certain ethnicities. The screening program falls under breast screen, and it's a 2 yearly mammogram from the ages of from 50 to 74. So it's the same ages as the bowel screening one. Important to note that women from the ages of 40 to 49 and those over 74 can also still have a free mammogram, but they don't receive a formal invitation. So there's not going to be like a text or a letter that's going to ask them whether they want to do one or to remind them that they should do one. However, if they come to you and you have a patient who's maybe like 45, wondering if they can have a mammogram because they might have had a lump, the answer will be yes. And I think it is covered for under the public health system. Within our primary healthcare setting as well, always important to remember to do a triple assessment. So that is examination and history, imaging, and biopsy. With that imaging, if they're over 40, we do a mammogram. And if they're under 40, we would send them for an ultrasound. The difference is because when you're younger or when the patient's younger, the breasts are a bit more cystic and dense. So a mammogram's not as good at picking it up, whereas an ultrasound will be more sensitive. This is the red book for breast screening as well. So I'll let you have a read through that. And then cervical cancer. So cervical cancer is an infection with HPV, and it's responsible for many cervical cancer cases. But there are many different strains of HPV, and some are more likely to cause cancer than others, and the ones that are more concerning include HPV 16 and 18. But cervical cancer is a very slowly progressing malignancy. So that's why screenings change to every 5 years now instead of every 2 years. So you might have some patients who maybe are still used to the 2 yearly screen, but you can just advise them that it's recently been changed to 5 years for that reason. Risk factors include sexual activity, not being immunized, smoking, family history. Signs and symptoms, typically it's asymptomatic, but in the later stage, they might have some symptoms including bleeding, whether that's just abnormal, randomly irregular vaginal bleeding, heavier than usual menstrual bleeding, or postcoital bleeding, abnormal discharge, pelvic pain or discomfort, and then if they've started to have some infiltration of the cancer, depending on where it's infiltrated into, might change the symptoms. So into the bladder, they might have some hematuria, into the rectum, some constipation. And if they're getting some edema in the legs, some pain, some hydronephrosis, that's the pelvic wall that might have been infiltrated. Etiology, so it mostly occurs in the transitional zone. So that's where our squamous cells turn into columnar cells of the cervix. And we have our CIN scoring system as well. For when you have a biopsy sample, you can score it according to where it sits. Prevention, we have our Gardasil 9 vaccine. It's given in year 7 to all Australian school kids. And it was only recently introduced in 2018, so there's currently still a catch-up program that you can ask patients if they want to do. For screening, we do our CST. They can now be self-collected or done by the doctor or the GP. Self-collection is only appropriate if the patient's asymptomatic and has never had a positive CST and has no family history. We do this from age 25 to 74 every 5 years. And positive results will either need a CST or a colposcopy. When you do a CST that's self-collected, it only tells you if HPV is positive or not and doesn't actually tell you the strain. So if that comes back positive, then the patient will actually have to do a CST at the doctor's. And when that one comes back, depending on what that shows, whether it's a higher risk HPV, so 16 or 18, versus if it's like a different type of HPV, that determines what happens after that. And you can see this in the Red Book as well. And I'm sure you'll learn about it a bit more in women's as well. But you can see it here in this flowchart, which I think is from women's, from the ONG notes, but also from the National Cervical Screening Program. What happens is that if HPV is detected, then they undergo reflex LBC, and then it depends on like what type of it is. So they take a sample at colposcopy, and then if it's HSIL or low grade or high grade, and then et cetera, and that will determine what happens from there on and the future screening program. And eventually, if negative for a period of time, they go back into the 5-yearly community screening. But that brings me to the end of my presentation. Please feel free to message me on Facebook if you have any questions. Very happy to answer them. Or you can also send me an email as well. But please check out GPSN and follow them on their socials. They have lots of great resources and very responsive to feedback. So if you have anything that you'd like GPSN to cover in particular, or anything that you feel, or any resources that you feel would be particularly beneficial that maybe we haven't done so yet, please do reach out and let us know.